everyone. Oh, 1 second. I'm getting a message from one of our colleagues. Oh, okay. Leslie Manson, she's trying to join. She's one of our core ECHO team members. Okay, so we will get started. Thank you for joining us today on this Friday, this warm Friday or cold Friday, wherever you are. My name is Matt Martin. I'm the director of this ECHO Hub on behavioral health integration management strategies. The purpose of this group is to connect people who are looking for strategies to improve their the management of their integrated health services. We talk about policies, about protocol, procedures, about financial strategies, and we hope that our time today will be useful to you. Our ultimate goal is to create a community of learning. We'd like to have a network of managers and administrators who are really trying to advance the practice of integrated care. So we hope that that you'll continue to come back for subsequent sessions. We try to meet every 2 weeks. We had to shift our schedule a little bit because of the upcoming conference in Denver, the CFHA conference, which I think most of you are familiar with. We can talk about that in just a second. But we also wanted to avoid some of the holidays that are coming up as well. So we shifted our schedule a little bit, but we do hope to keep meeting every 2 weeks on Friday. So the first thing that we do with ECHO is we go around introducing ourselves. And if you have a camera, you're welcome to turn it on so we can see your wonderful face. And just a reminder about the microphone, if you're not familiar with Zoom, you can mute yourself or unmute yourself using that little microphone icon down at the bottom. So when you don't have anything to say, please mute yourself so we don't get any background noise, and that will work out just fine. So let's start with introductions, and let's start with those people who are not here, a part of the main ECHO team. So let's start with Jessica from upstate New York. Just go ahead and introduce yourself and tell us where you work.
Hi, I'm Jessica. I was at the last meeting and got a lot of really helpful feedback. Now I'm here with video. I work in upstate New York at a private practice pediatric pediatrician's office, and I am the sole behavioral health consultant.
Great, welcome. Thank you, Jessica. Let's next go to Tara. Tara, if you go ahead and introduce yourself.
Hi, I'm Tara Budinger. I'm a psychologist. I work at Santa Rosa Community Health. It's a federally qualified healthcare center in Sonoma County, California. And we have just started a pilot program at a couple of our clinics, and we're looking at formalizing our program and rolling it out to our largest clinic, and just looking for resources and information about how to do that, because of course our administration is giving us zero resources to do this and aren't, I think, as familiar with the model. So we're looking to get everybody more educated on it, more buy-in, and a group of 8 of us are going to go to the conference next week. So I'm really excited about that.
Wonderful. Thank you, Tara. Let's go to Sarah Pedraza.
Hi, everybody. I'm Sarah Pedraza, a behavioral health consultant at MHC Healthcare. It's a federally qualified health center here in Southern Arizona.
Great. Thank you, Sarah. Let's go to Salithia Mitchell.
Hello, can you hear me? Hi, everybody. I'm Salithia Mitchell. I am a behavioral health consultant here in Phoenix, Arizona with Adelante Healthcare.
Wonderful. Thank you, Salithia. Let's go next to Daniel Need. Aloha. Oh, you're muted, Daniel.
Sorry. My name is Daniel Need. I'm the interim integrated health director here at Malami Ikeola, which is an FQHC in Maui. And I'm sitting with the soon-to-be permanent integrated health director, Angela Ross, who's joining me today to kind of get integrated into this meeting and all the goodness that it entails.
Wonderful. Welcome, Angela. Welcome, Daniel. Glad to have you guys here. Let's go to Kara Hill. Kara, go ahead and introduce yourself. Kara, we can't hear you. There should be, oh, there you go.
Sorry. My name is Kara Hill. I'm the director of our Integrated Care Initiative at Mental Health America in Greater Houston, where we work with various institutes of higher education, service delivery providers, and in the area of finance to help our region advance integrated care throughout Houston.
Great.
We're looking to create a Project ECHO model for that, for educational opportunities and clinical resources in Houston. So I wanted to get on this one and see how y'all do it.
Wonderful, Kara. Glad to hear that you're interested in ECHO. We'd be happy to answer any questions about our experience.
Thank you.
Let's go to the phone number. I see 602-369-3343. Go ahead and introduce yourself. You can unmute yourself.
Hello?
Yes.
Oh, hello. Hi, Matt. Hi, this is Leslie. So I'm not joining on the phone. This is Leslie Manson. I'm part of the ECHO team at Arizona State University. It's wonderful to hear so many familiar names there. Celicia, hi. And also I hear that there's a clinic from Santa Rosa. Wonderful. I ran the federally qualified health centers right up north from you in Lake Mendocino, Humboldt, and Del Norte counties. So if I can help with any materials or anything else, I'm more than happy to give you anything I got. So wonderful. Thank you all for being here.
Great. Thank you, Leslie. And Leslie's part of the ECHO team. Let's continue with the ECHO team. Let's go to Maria Hanlon.
Hi, everybody. I'm Maria Hanlon. I'm the project manager with the ASU Project ECHO team.
Thank you, Maria. Let's go to Christine Borst.
Hi, I'm Christine Borst. I'm faculty with the Doctor of Behavioral Health program, and I don't mean to be rude in my Sherpa winter coat, but I'm in Colorado and it's very cold, so I'm being a big baby about it, if you missed it earlier.
That's right. This is a judge-free zone, like Planet Fitness. So let's talk about Colorado, Denver. So the CFHA conference is next week. I know that some of you are looking to go. Christine and I and Leslie, we're actually going to be doing a presentation on our experience with ECHO. I can't remember what day it is, but if you're there.
Friday afternoon?
Friday, okay, Friday afternoon. You can look it up in the program brochure, and we'd love to see your faces there. We'd love to meet some of you face to face, and that would just be a wonderful experience. So look out for us. We'll try and look out for your familiar faces as well next week. Okay, so for those of you who are new to ECHO, like I mentioned before, the purpose of ECHO is to create a community of learning, and we focus on management strategies. The way that we do this usually is through case-based learning. So we try to learn from each other's organizations. We like to learn about the successes and the challenges that you're facing. So for those of you who are interested, we would invite you just to talk about a particular need at your organization. Tell us about what's going well, and then some of the things that you're striving to improve. And as a group, we will ask you some questions, and then we'll provide some recommendations for how you can move forward with your improvement efforts. So that's the format that we've been taking the last several weeks. We have just, I guess, as a side note, we are looking also at putting together a curriculum for managers. And this is something that we hope to roll out in the future. But until that is ready to go, we're going to be just doing a case-based style or format until then. So is there anyone here on the call that would like to get some feedback on a particular initiative or project or aim that you're trying to accomplish. Okay, if we don't have any takers, that's okay as well. We can pick a particular topic and just talk about some strategies or some ideas for that particular topic. Is there any topic that people would like to discuss as a group today? Whether it has to do with clinic workflow, with training. Yes, Christine.
So this came up in my integrated care consulting class a few weeks ago, and I would just love to hear other people's input because I've asked around and we haven't really gotten some solid feedback. We kind of are getting mixed reviews. So if we are looking at a bi-directional model, ethically speaking, how much primary care are psychiatrists able to do while working within the scope of their board certification and license and all that?
That's a really great question, and I'm happy to chime in when there is time to speak.
Okay, Christine, say the question one more time about psychiatrists.
So how much primary care are psychiatrists ethically, legally, within the bounds of their licensures, able to do in a bi-directional setting, or even just in a mental health home that's not integrated?
Yeah.
Where's the line there?
Can I ask a clarifying question? What is the benefit? So coming from a location where we are we have maybe one child psychiatrist within the 20-mile radius, what's the advantage of having the psychiatrist do primary care?
So this came up in a mental health home where the psychiatrist, they didn't have a co-located primary care provider. And so in the mental health home, that's where all of the patients, the clients that went there, they didn't have a primary care home. So they didn't have a place. They didn't have kind of the support that they needed. And so there was kind of the psychiatrist, it was just an offhanded comment too that started this whole thing. And we're like, wait, they were doing that? Really? Because you're right. It's probably not the best use of time, particularly when their psychiatrists are so needed for so many things. But this clinic, they had the need within their patient population, and they had only a psychiatrist, and they knew the patients weren't going to get help otherwise.
Gotcha.
Does that make sense?
Yeah.
It was like a convenience thing, basically.
So any thoughts? Or let's ask one question first. Who here has a psychiatrist as part of your care team? Oh, okay. So a few of you, yeah. Is that psychiatrist at your sites? Is it someone that that is an internal employee, or is it external to your organization? For how many of you is it an internal employee? Okay, that's helpful. So any thoughts about Christine's question is, what is the best scope of practice for primary care? Leslie, do you want to
This is Leslie.
Yeah,
I have some of it. Yeah. So can you hear me okay? I know I'm driving, so I just want to make sure.
Yeah, go ahead.
Okay. So, I've done a lot with consulting for law and ethics and integrated care for like 15 or so years, predominantly because I've had these problems where in our healthcare systems we've been sued or hit lots of things, and we had to figure it out, right? So this happens to be one of them, Christine.
Imagine that.
I chuckled to myself about it. I was like, oh, that's funny. So one is they should be dually board certified in family practice and in psychiatry if they're going to be practicing. Two is it's a significant waste of money, obviously, that you already identified, and that's just ridiculous. Three, they should be hiring a nurse because the nurse can actually handle those concerns. And then the psychiatrist could prescribe or can provide some sort of recommendations or treatment like labs and some levels of treatment if the patient is in an emergency situation or if the patient is needing something to do with their psychiatric medications or conditions. So say they have an antipsychotic, et cetera, on board, right? Or, it could be sleep aids or benzos. Those meds in itself complicate your nervous system and complicate your health system. So, and cause degeneration of other happenings, right? So they can cause problems with things like pain and pain management, diabetes, right? Dysregulation of, if they have diabetes and they have antipsychotic, so they can have difficulty regulating their blood sugar because of the antipsychotic on board. So there's all these dual things. So in those cases, they can justify ordering labs or changing any type of things like insulin, things like that. But if it's outside of the treatment and they cannot tie it to that, they are not ethically and potentially it can be illegal to be providing that care. Okay? It's not necessarily illegal, it's just whether or not someone wants to sue for it, right? So I should say it in that way. So if they can say that it is attached to their mental health and there is a need to do it, and they can do that, and then they can provide, like I said, the labs, the diagnosis, the treatment. But outside of that, they should really have someone else on board, like a nurse or an NP or something else, or just have him or her go and become duly board certified. So it takes a little bit of money, but that would be easier in the long run to know that they are firmly, evenly board certified, and they can provide care for, the kind of internal medicine side or family system side, if you want to say. That is a legal and ethical thing, considering I cannot go into what happened at our health centers. But we ended up making sure that we had our psychiatrist duly board certified, and it's fabulous because they can do both billing codes. But there's a way that you also have, this goes into the other side, right? I always talk about the 5 steps and setting practitioners up in integrated care. If they are duly board certified, their schedule, how they book patients, how they treat them, actually has to be done in a very specific way so that ethically the billing and coding is done correctly. So upon audit, no one gets dinged. So that's all. Now the likelihood of this person ever having a problem is pretty low because normally everybody wants care and nobody really cares, but that is the appropriate recommendation. And we had worked with many lawyers and the AMA and FFP and to make sure we knew the right answer. So that's what it was given a few years ago now, you know what I'm saying? So.
Thank you. That's very helpful. Yeah, it kind of came up organically in a conversation in this consulting class, and the student was like, "Well, but ours," and we're like, "Wait, what? I don't think that's okay. Are they double, boarded?" And so here was a follow-up question that we had, and I don't know if this varies from residency, but do psychiatry residencies, are they required to do like 1-year internship just in internal medicine or anything like that?
So that depends on where they go to school, and other people can answer that, and if they were in an integrated program or not. Most psychiatrists finish their medical degree and then do an additional, usually a semester or 2 that's focused in psychopharm, and then they go in and just do psychopharm as a primary modality. So, psychiatric. So they don't do other things unless they go through a DO school that has psychiatry. A lot of the DO schools will do dual training.
Okay.
And so they'll finish that, and then they'll go for the psychiatry after that, which is an additional year. And so all that depends on that. Now, they can still practice if needed, right? They're not a completely uneducated person, but it's like an internal medicine doc who will be in a primary care clinic and cut out sun cancer, right? Because they're good at it, and they take surgery classes now, and they can practice a little bit outside the bounds as long as they're getting the education. They have some sort of supervision or training that is provided, and they can document that and say, well, I've been doing this, and I get this extra training, and I go to this training every year, and I only go so far with what I do, and then I refer out to the specialist who then also checks my work, quarterly or whatever. So that's like kind of like the thing. And if they set up that system, then that person may not have to be duly board certified if they went to, like you said, a residency, etc. So there are those strict steps to it. Hopefully that helps.
Yes, thank you. Thank you. Somehow I knew, Leslie, that you would be the one to know the answer to this. Way to go. Matt, I think you're muted.
Okay, now I'm speaking. Very interesting. Thank you. Any other comments, questions about that? Yeah, Daniel.
I think systemically, I know in Hawaii, some of the HMOs will not reimburse if a patient is getting what's seen as primary care service from someone who is not listed on their insurance card as their primary care provider. So sometimes we get patients who have been seeing us, but we're not technically their primary care, and we have to have them call in the lobby and change that before we can see them. Otherwise, even though our docs are operating within scope, everything's ethically up and up, we simply won't get reimbursed. It's purely an administrative thing. So I don't know how that would work. If it's a group home, I guess that's still outpatient, or if it's considered I think that all gets sort of dicey. And obviously that's going to change state to state depending on state Medicaid laws, what insurance you're using, all of that kind of stuff. But I think in Hawaii, I could see us, that's the first thing we would run into before we even got to, if they were board certified, is we just simply wouldn't get reimbursed for those services. If the insurance company felt they were getting primary care services, and kind of like you were saying, you couldn't tie it really closely to psychiatry.
Yeah, that limitation makes sense. Any other thoughts or comments about this? Any experiences? I know, at least in my experience, it's rare to find a medical provider who is board certified in both some type of primary care specialty and psychiatry. It's a unicorn, so to speak.
Hey, Matt, this is Leslie. They're right on the unicorn, and they're also very expensive if you find them. Not that psychiatry isn't already, but the other thing I was going to say, that's the same that for Hawaii, it's the same here in most states. If you have the health home model, you have to make sure that patient is attached to that health home. And I'm kind of wondering, from what you just said, Christine, that you described a scenario that is a health home model, and that person is receiving their care. I'm wondering if they just have never been audited. Somehow it's falling through the cracks as far as where that, how that psychiatrist is boarded, and so maybe they're just like not noticing it till they do, which could be years from now or never. Right. So.
Well, and I think this is the danger too, and this is when we're talking specifically about doing technical assistance or consulting, which some of you might do, but it's tough when you're walking into sites not realizing what you're accidentally going to stumble upon, and then you have to be like, okay, well, I saw it, so we need to be ready to clean it up, which is kind of like what Leslie was just describing. So, yeesh, you might be walking on a landmine.
Wouldn't you consider using telehealth or something like that in that situation?
Leslie, can you respond to that about telehealth?
Oh yeah, Talithia, I think that's an awesome idea, and you know about telehealth very well. So yeah, if you're in that situation, that should be what that facility does. In fact, it's probably going to be a lot cheaper to hook up telehealth and add on a provider, even if it's part-time, and those patients receive certain types of primary care on a certain day. So the patients with certain types of complex conditions will come on Mondays and Fridays, and they'll be seen by the telehealth doc. Or again, they just get a nurse, or something else they can do. But that would be a really great answer.
Excellent. Any other final comments, questions about this topic? Okay. Let's continue and talk about another topic. We don't have any cases to discuss today, but another topic that we've been discussing here is about the onboarding process of new members of your integrated care team, and things like orientation, training. professional development. I was talking with a colleague who has a friend who's a psychologist who was trained in primary care psychology and was just hired by a medical home, but has very little understanding of PCMH and a lot of the things that go with that. And so this friend is actually struggling very much. It's been a fairly stressful experience. So one of the things that helps to relieve that stress is training, workforce development, orientation, all those kinds of things. Right now out in the field, there are competencies for behavioral health providers, but we don't know a lot about what nurses should learn, what medical providers should learn to be effective members of integrated care teams. At least in my experience, a lot of the time, the training is typically shadowing, typically informal didactics, maybe some formal supervision, but usually the person just kind of learns as they go along, sometimes stumbling and learning from their own mistakes, as opposed to like a fairly structured, formal training process that gets the person up and running as soon as possible. So there's a lot to learn when joining an integrated care team. And I'm curious about some of your experiences with your own training, but also when you've hired new members of your team, what are some of the strategies that you've used in getting that person up and going as soon as possible, as well as some of the challenges that you have faced as well?
So I can go, Matt.
Yeah, go ahead, Sarah.
So at our health center, we typically have like 4 to 6 medical providers. And honestly, because it's more in the rural location of our overall network, which includes like 15 clinics, the PCPs tend to leave very frequently. So in the couple years that I've been here, I've had the pleasure of having probably 16 PCPs leave and just as many come in. And we unfortunately don't have a formalized training program. So what I've recently encouraged and spent some time practicing, experimenting with is taking it upon myself to really partner with that new PCP to see what their learning challenges are, their pain points, all of that, and then see how I can mentor and kind of fill in those gaps, whether they're knowledge gaps or, training gaps, resource gaps. So that we can get them to be the functional, integrated primary care providers that they want to be, but knowing that it's going to take somebody close to them watching as they wince or, express that need to then kind of come along and coach and mentor them. And I just kind of explained to them that that's part of my role is to help shape, this clinic, this system. And I think so far it's been going really well, and the PCPs are really receptive to it. So that's what I've been doing.
Yeah, and Sarah, you're a behavioral health provider, and you have some supervision responsibilities, don't you, at your site?
Yeah, I'm the team lead for the consultants and such, but yeah, mostly I'm kind of just at our big main clinic, trying to help do a lot of like the pilot projects and stuff and kind of shape the systems and the protocols that we later put out to the smaller clinics.
Yeah. I know that one of the things that leads to burnout in medicine is having a lack of clarity about your role, and also having a sense of low power or low influence on the system around you. So training can be a strong buffer and prevention for future burnout. Let's see, I think we got some comments from Maria. She says, I believe that the agency cannot give what they do not have. It's been up to me to help train the team. I don't know if I could have done that effectively without the ASU program. Other comments about how you have oriented or done onboarding for new team members, or some of the challenges that you've faced?
Hi, Matt. This is Leslie. If nobody else comments, I'm happy to share.
Yeah, sure. Go ahead, Leslie.
It probably took me, a number of years to do it, but I created a set of videos for onboarding for all providers so that everyone can understand when they're hired, because there is so much turnover, etc. So I didn't have to keep trying to retrain the medical providers, at least not as much. So I did onboarding videos for all of our staff and then all of our providers, and did different types of videos-ish for the different types of people. And then after that, of course, doing the shadowing. So not only shadowing the medical docs and then having an exact script of these are the things that you need to answer, with them when you're shadowing and consider. And then also coming back, they have to shadow the nurses. They have to shadow the front desk. They also have to shadow me with patients. And so my patients knew, like when I see them, when I might have a person with me. And then I was very interactive with them. So just like very similar to residency and training there. And then I also have them do very specific modules that I set up online. And so I have some of these packages that I still give to sites now, and my sites out there will have them too. They're hiring new people now, and I'll give them the videos, which go over like psychopharmacology, they go over diabetes, they go over hypertension, they go over specific things. And then in certain times, I block off their schedule where they'll go and do those interactive modules. They have to do an exam, and if they pass it, then great. Then I kind of meet with them, do a hurrah, and then go on to the next module. And I time them out for so many months. And then each month that they're also doing that, they also have requirements to start to build some population health. They have to review the population health programs and care paths that we've already developed. And then I sit down with them and talk to them about that. And then they have to think about one that they want to develop that year, or an educational event for the community they have to develop that year. And so usually within the first 6 months, I'm starting to make sure that they're thinking about those things and they have that training. The training is very much mapped out, very specifically to give a lot of time to digest and to kind of just be in the clinic and manage that culture. But that's kind of what I do in a nutshell. Obviously, there's much more rigidity to it, but because there's documentation training and all that too. There's a whole bunch of it in there. But those are some of the things that I've done and that I recommend.
And Leslie, was that training for behavioral health or medical providers, or both?
So the big one is for behavioral health. And then the onboarding videos, I just do onboarding videos for the medical providers. And then when the medical providers come in, I do shadowing with them. And so they actually have to, so I shadow them and I give them feedback on their behaviors, because I'm also trained to provide feedback to medical providers. And so, because I have a certification related, so I go into their appointments, and then if they need me for behavioral health, I do that. But then I also give them feedback. And then I do that on a regular basis, or I did in some of my own clinics, and then in other clinics that hire me for consulting, I'll do that. But that's kind of where they get their training on what to do and how. And then all medical providers have to do my huddle training. That's mandated, and my communication training is mandated. So then those are the additional ones that the medical providers get. So that's kind of what we set up. Now, every clinic system has different resources, but some of those things I can share, if people want. If you get me, especially if you see me next week and you got a laptop, I got my laptop, I can pop it on something, give people the training. But those are things that we've done. We found them very helpful. So especially the onboarding, even for like front desk and things, we found that if we didn't do that onboarding, people were saying things that just weren't accurate, about our role and about everybody else in the health system. So it was very helpful.
Excellent. I know part of the gold standard for training and helping to avoid drift from the model that you're trying to implement is observation and feedback. So when you've onboarded your new care members, team members, watching them in action and then giving them specific feedback on their performance is the gold standard. I just want to introduce Maria and give her a chance to say hello. Maria Colon, do you want to go ahead and introduce yourself, Maria?
Sure, I'm Maria Colon. I am a LCSW. I was like thinking what I am. I'm an LCSW in a rural health clinic, and I am 7 weeks away from graduation from the DBH program. I'm counting the weeks down.
Wonderful. And who's your friend here?
I'm Ashley. I'm one of the family nurse practitioners at our primary care clinic, and I'm doing a project with integrated care as a component, and Maria suggested that I participate. So here I am.
Excellent. Welcome. Glad to have you both. So we're talking about training. I know that for behavioral health providers, There are some certificate programs throughout the country. I believe the University of Massachusetts has one that's online. And then we also offer some of our courses through a certificate program here at ASU. There are also lots of videos and lots of books available that people can read for behavioral health providers. But there's not a lot for nurses and medical providers. There's not a lot of content out there for helping them to know what their role is on an integrated care team. So one thing that my group has developed are some free modules. We have a curriculum that we have available online. And if anyone is interested in sending your medical providers to complete these modules, let us know. Or you can send me an email and I'll send you the link. Completely free. Just know that we're still in the pilot phase and we're looking for ways to improve it. But it's a nice introduction to medical providers about integrated care and about some of the specific skills that they can implement into their own practice. So just shoot me a quick email if you want to have access to that. Let's see. Yes, yeah, we have an opportunity to switch topics. Are there any other comments or questions about onboarding, orientation, and training?
Can I just add, Matt, that we found it really helpful, especially working in residencies, to have some sort of video like Leslie was talking about, so that the BHC wasn't responsible, like every month when new residents would come in and circulate through, that they weren't just doing everything from zero. So yeah,
it's especially nice to have something that's already built that you can just send them to, they complete it, and then you just talk with them, shadow them, work with them individually, kind of like Sarah Pedraza was talking about. Great. Okay, yeah, Maria, I got your message. Thank you. All right. Sarah, do you want to go ahead and ask your question about billing?
Yeah. So I was trying to think about how to keep this as narrow as possible, since billing integrated care can be a big topic, especially all the different ways that you can kind of think about a program, strategize your clinic, strategize your workforce, right? But I guess, and in thinking that maybe Leslie, Dr. Manson is going to be the best to answer this too, but just kind of curious what other people are knowing or thinking. So I'm in Arizona, and I'm wondering if anybody knows if there's been any sort of like changes to the stipulation that we have as far as documenting visits by the BHCs that are billing to incident of the PCP.
Sarah, will you say that last part again?
Yeah, if there's been any changes, like specifically in Arizona or just, CMS. I know a lot of people are talking about the 2020 stuff and how the codes, specifically like H&B codes, are going to be, reimbursed come that time, but we're still kind of in this fiscal year, and I'm seeing some changes at our clinic where we're, and I know Dr. Manson's had a lot of involvement, at least early on, with that billing strategy, and I'm talking now with leadership about it, because there's been a lot of changes about sending almost all of our consultant visits up for reimbursement, and so I'm wondering, I'm questioning and kind of messaging that I think this is a documentation error about not recognizing when the visits are incident to the PCP visit, but I just wanted to verify and check with everybody first if there hasn't been any changes that I should be aware of.
Okay, so you're wondering if there have been any changes to the incident to billing?
Yes.
Okay. Good question. Does anyone have any comments about this, about incident to billing and any potential changes?
To my understanding, there isn't going to be changes to it. I haven't seen anything. The main changes I've been seeing is the health and behavior code. So I haven't seen anything to my knowledge that there's going to be changes, but if there are, I would love to know about them.
Yeah, this is Leslie. Did anybody, I thought I pasted the link last week or a couple weeks ago to the changes that were proposed. Did we get that down in like notes? Just wondering.
Yeah, we did get it down. Yeah, I'll send it out.
Okay. that'd be awesome. So that would be helpful because it's like 200 pages of changes, right? And honestly, I didn't even look up the incident to billing. Incident to billing is actually, so there's overall incident to billing rules, okay, and regulations about who can do it and why and blah, blah, blah. But then each billing code, it has its own rules related to incident to. So it's just crazy, right? So it may be that certain E&M codes may not be eligible for it or could be eligible for it. So that could be changing, and that's often changing. I don't recommend anyone ever doing incident to billing. What I recommend people doing is direct billing or assisting the medical provider to optimal bill, which isn't necessarily incident to. It means that you go in, you provide care with the medical provider before, after, during, blah, blah, blah. But then the medical provider bills their code based off of medical decision making that you helped with. That's not incident to. That is optimal billing. So I know it's so close in terminology and even structure about how it goes, but that's usually what I recommend because incident to billing is really kind of its own entity, and you know, you just got to make sure that your clinic is eligible for it, your person is eligible. Only certain types of providers are eligible depending on insurance and depending on codes. So that's all I can tell you, and not without knowing specifics, if that makes sense.
Thank you, Leslie. I just sent the link to the information about the codes.
And I will mention one other thing because Sarah, you're in Arizona, and I'm passing Maricopa here in a second. Arizona has a tendency to pass reg and rule changes throughout the year, and so I know like a couple of years ago I caught some pretty big changes from their rules and regs for SOHCs, and I had to send them out to them and be like, hey, are you aware? And some of them were, some of them weren't, but it could be that there was a reg change and I didn't see it, but they are very well known to make changes throughout the year, just so you know, in Arizona.
Yeah, because we're just seeing some big changes here, and I'm not sure if it's just our billing department not being educated how we've changed our structure for billing. But we're sending, you know, pretty much everything up now, and the patients it's essentially being treated as when the BHC sees the patient on the PCP as two separate and distinct visits. And that's why I pull in that incident to language, because we recognize them as, you know, being part of the same visit, and the BHC providing treatment, you know, with on behalf for the PCP, but that's all kind of encompassed in their visit. So it's just a little confusing to me. I don't have a lot of insight into how that changed, why that changed. We're going to do a workforce group on it to figure out what the change has been and why it came about. But yeah, I just
okay. I can answer that. So I think I can answer that. So there was a few years ago where the rules and regulations in Arizona specific changed. It's actually a rule and regulation that's in California and some other places that say at a MQHC and at specific types of clinics, you cannot see the patient for the same thing on the same day, okay? And so if the medical provider is putting in a diagnosis of, I'm just going to make it up, right, diabetes and depression, and you saw them for their diabetes or depression, whichever one, then they can't do two separate billings because it's a continuous appointment. But what they can do and make ridiculous amounts of money is separate it and make the PCP do the diabetes billing, and then you do the depression billing, and then they're going to make double their amount. And Maricopa, you know, some of our sites make a large reimbursement amount because they have a wraparound rate, and SOHCs are eligible for. So they would make a very good, handsome amount of money for that visit. So if you can make it two distinct and separate visits, then it's a very solid, firm business structure. And that's encouraged for people, but the documentation has to be separate, and you have to meet both billing rules. I doubt they were doing incident to billing. What I'm assuming they were doing is they were billing a optimal code and optimizing the code and billing for both of you. If they were doing incident to, they probably didn't have enough to be able to do it, so now they're switching it because they realize they didn't. Incident to billing is very difficult. So it's either optimal coding or it's going to be doing the two visits. Hopefully that makes sense.
Can I ask?
And the 2 visits have to be separate diagnoses. Okay,
Leslie,
go ahead.
so I'm working to get up to speed on the terminology. Can you just clarify, so incident 2 billing versus the optimal billing, which would be like, so what I often do for my warm handoffs is the MD will put down a like level 3 code or whatever it is based off of complexity, and then I'm adding on a like 90833 therapy code with E&M service.
Okay, so that's a separate code. So incident 2 billing is when a medical provider says, I have this E&M code, you know, that, or whatever code that they're using, and they say, I'm not going to see them for this. I'm going to have the nurse see them instead. And then the nurse sees them, okay? The medical provider checks in or provides supervision or whatever, and they may or may not have ever touched the patient, the medical provider, because it's incident 2, so they don't have to. But only certain people qualify for incident 2 billing, and only certain codes, and in only certain ways. That's incident 2. Now they could be trying to link your codes and say that the referral was incident 2 that, but that's still 2 separate billing codes and 2 separate billings. They shouldn't be billing they can't bill your code under the medical provider. That needs to be under you. Unless they're doing incident 2 and they're flipping it somehow and having the medical provider like bill for your code instead of for theirs. I don't know, that's weird. But I have to think through that one. But that's that. Optimal billing is where the medical provider goes, oh, this is a level 2, but I'm suspicious it's a level 3. And because they're usually complicated, but I don't have time to go through all that with them, I'm going to send them to you. Then you see them and you're like, yeah, I dealt with this extra complexity. This is what I did, yo-yo. You give it back, and the doc's like, totally yo-yo. I agree, and I'm going to do my medical decision-making off of that. Then they can code level 3. That's optimal billing. Okay, hopefully I'm making that very distinct. Incident 2 means incident TO. Incident 2, another provider does the service. That's the way to say it.
Thanks, that really helps.
Okay, I was like, does that make sense? Okay.
Does anyone else have other experiences with incident 2 or optimal billing? Or Sarah, do you have any other follow-up comments?
Well, just more like a question, because if we're doing optimal coding, let's say, I think maybe the consultants were thinking it's incident 2 because the PCPs, you know, will document, you know, the depression, diagnosis, anxiety, diabetes, whatever. They're not touching it because they know it's, you know, related to lifestyle or whatever, some sort of like social factor that needs to be adjusted. So the PCP is putting it in their note, but saying, you know, the BHC saw the patient for that. But let's say, you know, on the back end, billing is coding it optimally, you know, so doing it as a separate visit so they can have 2 separate and distinct, and then, you know, utilizing like the depression diagnosis, whatever. Then that brings up that whole bit about licensure for the behavioral health professional. And now it's going under their clinical license. You know, informed consent has been, you know, a little separated then because it would have to be not necessarily just what the medical person did, because now they're getting billed behavioral health stuff. And so the issue comes up about accurately educating, informing the patient.
So at your site specific, all that's been done in the consent form. So patients have to complete a notice of privacy practices and a strict consent when they walk in the clinic. I believe your clinic system is one of the systems that have updated it to be an integrated clinic, so they're licensed as an integrated clinic. They provide integrated care services, and their notice of privacy practices and sharing information is all up to date. So they can provide all that at the front desk when the person checks in. You may not see that or hear that, but that is what happens. Now your role can be, and I think I've given scripts before, possibly to your organization, is that in your script you could say, hey, I'm a behavioral provider, I'm also a blah, 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 you know, this is what I'm going to do today, you know, and people can have the verbal ability to say, I don't want to see you, get out of my room. And that is enough that they've signed it and you have an introduction. So that's all you need ethically and legally related to that. So just as a reminder, optimal coding is that only the medical provider is billing. If they're doing both of your billing, then that's going to be the best for the clinic system. That's a lot of money that's coming in that they've been missing. And I know they talked about like switching over eventually to that. So then that could be what's happening, and then it would be under your license, your NPI number, meaning the mental health person's NPI number they'd be billing under. And it has to be really important that you guys learn that in Arizona, they have this law or regulation that they put in. And they, as of, I think it was early last year, the state didn't have a way to actually pull whether or not the clinics were violating it other than on personal audit in person. But they're figuring out a computer system to do it. But what it is that they can't share diagnoses, because if the medical provider starts to put in those mental health diagnoses and documents on the mental health, and you did, and you billed for it the same day, all that, they can come to the state, can eventually come back and say, that's the same visit. It's called a visit extension, and you can't do an extended visit. And so you'd have to have a distinctly separate visit. And that means the documentation and the diagnoses can't be the same. And trust me, I worked with the state on this very particular issue and went through, what if there's a warm handoff? And this is the code, and they diagnosed this, but they only did this. So I have all of those answers written out by the state, and so of how they're auditing it. But so you have to make sure that you all understand that part and are very well trained so that you don't come back in an audit and have to pay a bunch of money back. Okay, I'm shutting up now.
No, that was very helpful. Thank you for that. Yeah, and I think that's what I'm noticing too, is that there's been a bit of a breakdown in how the front office staff and billing are educated, to the point that we even had one of our leads call billing as though they were like a patient, and they really couldn't answer those questions to like accurately inform the patient how much it would be, like if they did have additional questions, or just basics on how we're billing. It's a little up in the air. So I think it's a lot of just it changed, and making sure that front office staff and billing are educated to accurately inform patients.
Yeah, I recommend a script. That's how I do all the trainings, is writing out scripts for the front desk, and then a poster, and then stuff in exam rooms. So you do want to do that, especially when it comes to billing, and making sure that you're doing your due diligence to understand that people understand the consent process of that, because technically they're consenting for an extra bill. And so I'm really strict with sites on that if you're going to start doing that, give them a script in the front desk. They need to check dual benefits with every patient, regardless if they're going to see you or not. And then they need to have a poster that sits behind at every front desk, regardless of where it is, even at your mental health side, and then also obviously your primary care side. And then have that in a poster saying, if you were an integrated care team, if you see one of our people, you may have an additional copay up to $40 or up to $60, like whatever it could be potentially, and or sliding scale, right? Blah, 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 yay, we're happy. And then you have that in all your hallways and exam rooms here and there as well. So those things are important. And so especially when you hit your Medicare population, that they are very low income, and a lot of Medicare has high copays. So that's an additional $40. That's $80 that this elderly patient's going to pay out in one day, to the primary care and then to you. So I do think it's really important to really do that type of education. I have samples if you guys need that too.
We do.
Okay, great discussion. Thank you, Sarah, for initiating that. So we are at the end of our time today. Thank you everyone for coming. I hope you all have a great weekend, and I hope to see many of you in Denver next week. I know Christine will be there. The next time we're going to meet is in 2 weeks. That's going to be on, what's today, the 11th, I think? Today's the 11th. Okay, so it'll be 2 weeks from today. So hope to see you again on that Friday. Thank you, everyone. Have a great weekend, and we'll see you soon.